How does nutrition relate to colon cancer?
It is estimated that practically 50% of digestive cancers are related to nutritional habits. Colon cancer has become the most common cancer in our general population.
I want to ask you about other types of cancer, pancreas, liver, stomach. Are they related to nutrition?
That's right, processed meats, red meats, and a lack of fiber in the diet, regardless of tobacco and alcohol.
What nutritional guidelines would you give your patient?
Diets with a very high content of fruits and also additives.
Are any suspected of potentially harming our intestinal barrier function or under scrutiny?
Well, saccharin and all those sweeteners are not well tolerated.
What happens in the intestine while fasting?
Food, digestive diseases, nutrition, and the digestive system live like Siamese twins.
Dr. Pilar Esteban, welcome to Better Than Yesterday. How are you?
Very well. Thank you so much for being here. It's a pleasure for me.
Really looking forward to talking about lifestyle habits and digestive health. You know that everyone is asking for this information because it's something that affects, I think, almost everyone, if not everyone, right?
Exactly. The truth is that symptoms in digestive disorders are on the rise. And then everything related to food intolerances, allergies, digestive symptoms, they are very, very common in the general population. Yes.
Well, we're going to talk about many things, but maybe I want to start with the most serious and what I think is the priority, which is cancer. Digestive cancer, colon cancer mainly. And then there are others, but I want to ask you, what is the relationship between nutrition and colon cancer?
Well, look, it is estimated that practically 50% of digestive cancers are related to nutritional habits. As you know, colorectal cancer has now become, in 2025, the most diagnosed cancer in the Spanish and European population.
Number one for men and women.
Men and women, number one. In women, it's breast cancer, and in men, it's prostate cancer. But when you look at the global terms, colon cancer has become the most common cancer in our general population. Therefore, that's why there are preventive strategies and colorectal cancer prevention programs. And here, diet plays a key role.
Okay, now we'll talk about specific guidelines to follow and to avoid. But I also want to ask you about other types of cancer in the digestive system, pancreas, liver, stomach as well.
Yes.
Are they related to nutrition?
Exactly. I mean, colon cancer has been linked to processed meats, red meats, and a lack of fiber in the diet. Gastric cancer has been linked to smoked foods or products with a high content, for example, in soy, regardless of the presence of Helicobacter pylori.
In soy or in sodium?
Soy also has a high sodium content. For example, gastric cancer is far more common in Asian countries.
I didn't know about that connection.
Yes, gastric cancer is very high. Above all, the incidence rates are very high in Asian populations. Yes.
They base their protein content, for example, on soy, right?
Yes, and it's also linked to smoked foods, okay? Pancreatic cancer, well, pancreatic cancer is associated with poor nutritional habits as it is. Insulin resistance, low-grade chronic inflammation, regardless of tobacco and alcohol, obviously.
Of course.
That also... And liver cancer, well, nowadays liver disease is metabolic, not alcoholic. That is because everyone associates the liver with alcohol, which does indeed cause direct toxic damage. But liver disease is also related to an increase in fats. Within the context of metabolic syndrome, which has now become the leading cause of liver transplants in our country, right?
The leading cause...
of liver transplants. Now that we've defeated hepatitis B and C with powerful new drugs, we've managed to treat those diseases, which are also liver procarcinogens. Before, many patients with hepatitis B and hepatitis C were transplanted, but now with the new drugs, well, they have cleared the virus, and there are response rates of almost 90%.
A success.
Therefore, however, liver disease is metabolic, overweight, and obesity continue to rise. And currently, it is the leading cause of liver transplants in our environment.
This is what used to be called non-alcoholic fatty liver disease, right?
Yes.
Wasn't it later called incorrectly?
Mobile Army Surgical Hospital.
Or Mobile Army Surgical Hospital, a metabolic associated hepatic disease, right?
Yes.
Something like that.
And now they want to, it's liver disease, metabolic, like to encompass it more in a concept. Not just a disease that affects the liver, but it's in the context of a global metabolic syndrome, right?
That is to say,
obesity, insulin resistance,
Of course, I think that's a very powerful message right at the start of the episode. Insulin resistance, obesity, chronic inflammation, that adverse metabolic context can lead you to eventually need a liver transplant. Cirrhosis caused by that, and a liver transplant.
Exactly.
I think people don't really have that in mind, right? When we talk about, well, is obesity a disease or not? We're talking about a liver transplant, you know?
Of course, because it causes, in the natural history of the disease, it initially causes what people might know as fatty liver, right? I have fat in my liver. Well, indeed, the hepatocyte, which is the liver cell, gets filled up with, let's say, like micelles or fat vacuoles, which in principle, well, it would be. On ultrasounds, we can see it very clearly as we see a liver that looks whitish, and from there it starts producing and causing hepatocyte inflammation, okay? So there starts to be an increase in liver enzymes, usually glutamic oxaloacetic transaminase, glutamic pyruvic transaminase, and transaminases. When that isn't treated, when it isn't cured, or preventive, corrective, or pharmacological measures aren't taken. In short, the overall progression of the patient in terms of their disease stage, depending on what they need, well, in the long term. It's like a silent killer that's causing inflammation and liver fibrosis, inflammation, fibrosis, inflammation, fibrosis, and there comes a point when it turns into liver cirrhosis. Many patients say, but I don't drink any alcohol, I don't drink. Right, but liver disease isn't only caused by alcohol or viruses, there are many more causes. And nowadays,
it's the leading cause of transplants.
It's the main cause. When you already have a cirrhotic liver, the prevalence or the likelihood of developing hepatocarcinoma, a liver cancer, increases significantly in a cirrhotic liver.
And also we can't compartmentalize. Casually, since many obese people with metabolic disorders also drink, right? That is, both harms occur simultaneously, right?
What happens is that in our country, we often think that drinking or alcohol is only when people consume very high toxic doses of alcohol. And then, well, that's where each patient's individuality comes in, because there are some people who, even when drinking socially acceptable amounts of alcohol, such as those that might be considered normal,
a daily beer,
like with beer, I have a glass or two of wine every day. When you go over 60 or 80 grams of alcohol a day, which you can have in just 4 drinks. Chronically, since adolescence or since your 20s, let's say, so when you're 65 or 60, over time. All that chronicity
has accumulated a lot.
That accumulated liver toxicity in genetically predisposed patients, that is like everything that is genetically predisposed, well, it produces.
There you have it.
The whole natural history.
Interesting.
That's regarding alcohol, then alcoholic hepatitis, because then we have metabolic hepatitis, and then the reality is that it all gets mixed together.
It's combined.
It gets mixed together, yes.
Great. Okay, let's start giving clear guidelines. If we are a person, imagine having a father or mother with colon cancer, and we say, I want to do everything I can to minimize as much as possible my risk of colon cancer. Let's focus on nutrition. What nutritional guidelines as a digestive specialist would you give your patient?
Well, the main thing and what the colon lacks the most is optimizing fiber intake. Fiber is essential for having regular bowel movements and reducing the prevalence of colorectal cancer. That has been well studied in the literature and it's key. Colon cancer has been linked to lower levels of micronutrients like folic acid, calcium, and vitamin D. So, optimizing your diet by making fruits, vegetables, and greens the foundation of your meals is key. And then there are certain products that generate a lot of controversy, such as red meats and processed meats, which can also be considered pro-carcinogens. All right, we could differentiate processed meats, which have indeed been linked in large epidemiological studies. As considered by the World Health Organization as a type 1 procarcinogen, and red meats for red meats, the excess, right? Let's say. A consumption of about, more or less about 500 grams of red meat per week is allowed. It's classified by the World Health Organization as a type 2 procarcinogen, right?
Like with less supporting evidence.
Exactly. I don't want to demonize red meat, which, well, is an important source of protein. But a diet with a high daily content of red meat can for the colon. No,
It's not the best.
it's not the best.
And regarding the fiber, I'd like to understand a little more. Besides regulating bowel movements, their protective mechanisms, because I think it's often underestimated, right? Yeah, the power of fiber, or it's considered as, no, fiber is an essential because we don't need it to survive. But how does it protect us? Why is it so interesting?
Well, look, the first thing you need to know is that we, our human cells, aren't able to digest fiber, okay? So they need the gut microbiota to be digested, let's say, or metabolized. What happens when we have a high fiber content? Well, our gut microbiota, with that good fiber, is going to produce a series of products such as short-chain fatty acids like butyrate and propionate, which have anti-inflammatory activity. So besides being the energy substrate for the colonocyte, which is the cell that lines the walls of the colon, it also reduces that intestinal inflammation. Let's call it low-grade intestinal inflammation. So it has a very interesting protective effect because let's say it's the substance that our microbiota needs, their prebiotics, right? I mean, fiber acts as a prebiotic and it's like the substrate for our gut microbiota. Well, to produce interesting metabolites that they're going to have.
The colon benefits from them, right?
The colon benefits from them and many other organs will benefit as well. As I always say, our digestive system is not just a mega organ for absorbing nutrients and excreting waste. It is a metabolically active organ with many neuroendocrine and metabolic activities, and it produces all the intestinal cells and the microbiota that accompanies it. There are more than 50,000 metabolites identified, which will have an impact on health, obviously on digestive health, but also on cardiovascular, neurological, metabolic, neuroendocrine health, among many others. That's why I always say that strengthening our intestinal barrier function is an investment in overall health, because that's how it is.
Yes, yes. And also, well, if we make the analogy with the skin, as soon as the skin loses its barrier function, a lot of problems start to appear, right? And in the digestive system, even more so. Of course, let's say that a diet without fiber basically shifts the microbiota toward a more pro-inflammatory microbiota. And in the end, when the microbiota isn't right, the main ones affected are us. It's the cells of the colon at the local level initially, and that secondarily causes the whole body to function worse. So, well, we can put that idea that fiber isn't essential in quotation marks. I mean, really, if you want to optimize your health, that is, have the best health you can have. Fiber is essential. I mean, fiber is necessary.
Fiber is essential and it's necessary. Next, let's discuss the types of fiber: soluble, insoluble, fermentable, and non-fermentable. Because there are many patients who may have some difficulty, let's say, metabolizing certain groups of fiber. Well, then you'll have to regulate with the different types of fiber available, especially in your diet, so that your intestine doesn't become deficient.
And there's an adaptation effect to fiber consumption, because what I see in patients is that a person who has a poor diet, very processed, very low in fiber, usually starts suddenly taking a lot of fiber. And of course, they don't tolerate it well. I understand that it's much smarter gradually increase fiber intake to let your microbiota adapt to fermenting it. Work with it and be able to tolerate it with little bloating or discomfort, right? Because I think there are people who start taking a lot of fiber, they get bloated, they start having unbearable symptoms and say, this isn't for me, this is bad for me, right?
Of course, that's where the importance of a good diagnosis comes in. I mean, if there's a patient who has a lot of digestive symptoms with gas, bloating, or poor tolerance to certain types of fiber, well, hey, consult a doctor. Let's diagnose the case, make sure there's nothing underlying, and from there we can start working. I usually always work with nutritionists on my team to optimize the introduction of fiber in an organized way. Well, fiber and FODMAPs, which are also fermentable substances. When I talk about fermentables, what does that mean? That they can produce intestinal gas. And in certain patient profiles where it's indicated, that's when we do nutritional interventions that are initially low in FODMAPs.
Okay.
I suppose people are already familiar with it. But anyway, that's a nutritional intervention that consists of 3 phases. The first phase is to eliminate fermentable foods, the FODMAPs. A second phase of gradually and systematically reintroducing them. And also in terms of quantities, timing, and method, each of the food groups, and then a third phase of personalizing the diet. We can't stick to a diet. An indefinite low fermentable oligosaccharides, disaccharides, monosaccharides, and polyols intervention because it would be micronutritionally deficient and would harm our gut microbiota. But for that reason, to do a low fermentable oligosaccharides, disaccharides, monosaccharides, and polyols intervention, you need these 3 steps.
Yes. Beyond ultra-processed foods, beyond processed meats, and in this case, red meat. What other food group or products harms our gut and is widely consumed by the population?
Well, I would say that maybe nowadays. Simple sugars and fructose, agave syrup, diets that are very high in fructose, and also additives and some sweeteners. So, a lot of the diet or of our environment, of the products we consume, are full of simple sugars, hidden ones, that go unnoticed. And especially all the products that say sugar-free are sweetened with fructose and sorbitol, mainly so that the consumer still gets that sweet taste. But of course, those high levels of fructose and sorbitol damage our intestinal barrier function and also have a very strong metabolic impact, okay? A very negative one. And then, the excess of sweeteners and certain additives used in food can also play a role. And some xenobiotics, right? Like insecticides and pesticides that are used to preserve fruits and vegetables. And even though I don't want to sound the alarm with this,
it's not being chemophobic, it's just that,
it's not a chemophobic message. But they're there, they've come to replace, or to cure us of many infectious diseases that we no longer have or that we have much less of now, right?
Yes, but there's a downside.
They have that downside, but authorized ones are legal. And for the consumption that's being used in the food industry, they're legal, right? But it's true that I think they have a very negative impact on the intestinal barrier function and on the...
Of course, that's always the discussion. Just because something is safe in the short term doesn't mean it's healthy in the long term. So there are 2 things I want to ask you about. I'll cover this in more depth. One issue is additives, which are found in many foods and products. Are there any that are under scrutiny or suspected of being potentially harmful to our intestinal barrier function?
Acetate, saccharin too especially. Many of them, they're actually complex fructose molecules. They're fructans and they're complex fructose molecules. So all those additives, all those sweeteners, they're not well tolerated. And some like carboxymethylcellulose polycarbonate 80, E301 or 311, all those kinds of products. Large meta-analyses have shown this, that people who consumed a high amount of sweeteners had a slightly increased incidence of digestive cancer, okay? Many times, maybe, we don't have studies that say one specific sweetener is bad, but rather the widespread consumption of many sweeteners in the diet.
Continuous exposure to large amounts, even if they are safe from a toxicological point of view, can cause some digestive problems in the long term.
That's right.
Having a sweetened yogurt doesn't automatically cause problems. I don't know, a loss of intestinal barrier function, but maybe 15 or 20 years of daily consumption of many sweetened products, it may cause digestive issues.
And now there's a lot of talk about that palatable taste, the umami flavor, which has also been studied a lot in terms of how it alters the gut microbiota and the intestinal barrier function, that constant search for that palatable food. That which increases dopamine and causes that relapse.
This was typical of Asian food, right?
Yes, the umami flavor comes from that concept. It's a word, Asian, yes.
Okay.
Monosodium glutamate, which is mainly what gives that flavor like enveloping, right? Palatable.
Okay. Alcohol is a digestive toxin, right? Even if it's not linked directly to digestive toxicity, it's still harmful, isn't it?
Well, it causes an increase. Alcohol is considered one of the major procarcinogens in the intestines, colon, liver, and stomach cancer. It's practically like enemy number one. The pancreas is very sensitive. Alcohol and tobacco are two direct toxins to the pancreas. And it's related to an increased incidence, indeed, of all digestive cancers.
All right, well, we've reviewed things to avoid if we want to minimize the risk of digestive cancer, and there will be more as well. I also want to ask you about a second, less serious group of problems, food intolerances. Why, Pilar? Does it seem like there's such a massive increase in food intolerances? And now, well, there's practically no one left who doesn't eat something that causes them some digestive discomfort.
Well, I think it's due to several reasons. First, I believe we live in a dysbiotic world that alters the microbiota.
A dysbiotic world?
We live in a dysbiotic world that causes intestinal dysbiosis. So while food intolerances are typically produced, the mechanism involves the entire cell. The enterocyte, which is the cell in the small intestine, has to produce a series of enzymes, the disaccharidases, to break the bonds of molecules, such as lactose and fructose and sorbitol. So this cellular functionality is altered when there isn't a strong intestinal barrier function and it can't produce. Or over time, or over the years, those digestive enzymes that are needed to metabolize and digest those complex sugars. And then there's also the increase in diagnosis, because now we have diagnostic tests that are more precise and more accessible. Well, that also means they're diagnosed more frequently and are also better known. And I also think that those changes that happen also make the patient more aware, of their diet, of their food. They're always searching, always trying to justify the digestive symptoms they have. We're always looking for something in our diet to blame, like lettuce, dairy, or gluten, right?
Of course. Do you think there's a factor that makes people more sensitive to digestive symptoms? Maybe we lived with them, but 30 years ago, we didn't notice them as much as we do now. Or is it, of course, because there's the question, right? Hey, is our digestive system more sensitive now than before, or are we simply more aware of this?
Both causes come together. I think right now we have a weaker and more sensitive digestive system, and there's an increase in visceral hypersensitivity, and there are changes in the microbiota and dysbiosis that they produce. They encourage that cycle. And then also, there is a greater awareness among the population. There are more and more people who understand the impact of diet on health, which is good. Well, that's what they're looking for. They have digestive symptoms and they're always looking to blame a certain food group. And there's a weaker intestinal barrier function. Yes.
Okay. What are the most common intolerances among the population?
Well, lactose intolerance, fructose intolerance, sorbitol intolerance, fermentable oligosaccharides, disaccharides, monosaccharides and polyols intolerance, and fructan intolerance. And to alpha-1 antitrypsins, and then histamine intolerance, age deficiency.
And can more than one exist at the same time? Okay, things are getting complicated. And the famous small intestinal bacterial overgrowth, can it mimic any of these intolerances or overlap with them?
Absolutely, because the patient's symptoms are the same. The patient comes in complaining about gas, bloating, and flatulence. That causes them pain and sometimes changes in their bowel movements, usually, although not always, with a tendency toward diarrhea. So usually when the patient comes to the appointment, they already have a checklist with a list of possible food enemies that always start with the same ones. I've cut out gluten, I've cut out lactose, I've cut out this thing, that thing. And many times underneath all that, what there really is small intestinal bacterial overgrowth, It's still an overgrowth, a bacterial overgrowth in the small intestine, and it's still an increase in bacterial groups. Overgrown in the small intestine. That dysbiotic microbiota, which can't absorb, ferment, or metabolize many of the products we eat, causes the food to ferment. Fermentation produces intestinal gas, which distends the intestinal loops. That distension causes cramping, twisting, colicky pain, and then it causes something called osmotic diarrhea. That's because that solute hasn't been absorbed by our body. Well, it has to
come out of water.
It has to find its way out somewhere, and usually, it causes diarrhea. Well, that's it. They're not frequent, but they're very forceful. We can probably understand that very easily after a night at the fair, right? When you've had a lot of rebuito, you've had, the next day you wake up. Of course, those high amounts of fructose and sorbitol that your intestine can't metabolize, the next day you wake up bloated with gas and needing to go to the bathroom, right? With so-called post-rebuito diarrhea.
Oh, I didn't know that had a name. Careful, the Malaga fair is coming.
It's not scientific. It's not a scientific term. It's a colloquial term, right? But I think anyone could find themselves in that situation.
Yes, is to understand it. Yes.
To understand it?
You sometimes mention a term in a publication. I understand that it's at a popular level, not academic, but it catches my attention and I'd like to conceptualize it. That's the weak gut, right? In the sense of do we now have a weaker gut than before? Or what can we call a weak gut? Because it always catches my attention that there are people who seem to eat whatever they want. They tolerate and absorb everything perfectly, feeling wonderful. And then there are those who eat just a little something outside their usual diet and have to go to the bathroom. And the poor guy or girl can't eat out. They're always watching what to eat, what not to eat. They even develop a fear of eating, a neurosis around food. And what makes both intestines different? A strong intestine that's able to absorb and eat well, and another intestine that isn't?
Well, like everything in life, each person's individuality, our genetic factors, that already predisposes us to certain illnesses, right? It's like someone who smokes a pack a day and doesn't get lung cancer, and another person who just smells 3 cigarettes. Or
his father's secondhand smoke?
Or so-and-so's secondhand smoke and they get lung cancer, right? What's behind that? Well, there must be some genetic polymorphisms, a basic genetic substrate that predisposes you to having certain different diseases, which we don't know, right? You're in the world, but we don't know what your future diseases will be, or we haven't fully identified them yet, right? Although there are studies and genetic tests that help predict things, the same applies to the intestines. Basically, I always say that the intestine has a barrier function that's made up of many elements. The first element, if we look at it from the inside layer, meaning from inside the intestinal lumen outward, we start with the intestinal mucus. All right? It is made up of bicarbonate, a lot of immunoglobulins, antimicrobial peptides, and that's where the gut microbiota is located.
The microbiota lives in the mucus?
The microbiota lives in the mucus, which is in close contact with the enteral cells, but that's where the gut microbiota lives. It's in that mucus. That's how I explain it to my patients. It's like having a layer of varnish. This layer of varnish protects your mucous membranes in the digestive system. Well, when a door loses its varnish, it
starts to deteriorate.
It cracks, right? And then a situation starts to appear that we call low-grade intestinal inflammation at that level. So it causes an increase in intestinal permeability of the tight intercellular junctions. And that can cause an increase in antigens and toxins of xenobiotics that we introduce through food, okay? That can enter your body into your intestinal barrier function. As you know, our intestine is probably the largest immunological organ in the body. Right behind is a tiny cellular layer, which is a single layer epithelium, meaning it's not like the skin where you have the stratum corneum.
A single line of cells?
A single line of cells, that's all. Right below then, we have a cast of immune cells, lymphocytes, B lymphocytes, T lymphocytes, antibody producers, immune cells, and some lymphoid areas, okay, that are clustered together, like the Peyer's patches. Let's say they are the guardians of our intestinal and overall health. As I often say, throughout life, we will ingest almost more than 70 tons of food, liquids, toxins, and medications. Of course. So even though it might not seem like it, your intestinal barrier function is very exposed to the environment. I mean, with everything you ingest from your diet. Well, that barrier function has to be constantly alert, watching what you're introducing through your diet, what's good and what isn't, what needs to enter your body and what needs to be discarded. So when you're constantly, I'm not saying if you slip up one day with your diet or something specific, but when that toxicity, you keep accumulating it over time, then there's a very extensive neural network. It activates those neurons that are inside the wall of the digestive tract and causes pain, neural excitation, changes in contractility, pain. And then there's a concept that we doctors talk about a lot, which is visceral hypersensitivity. In other words, it's like that exaggerated sensation to certain digestive stimuli that for some patients pass by absolutely.
Without you even noticing.
Without you noticing, yet some patients have a threshold for visceral pain that's very exaggerated.
Do we know why visceral hypersensitivity develops? Who is at risk, if it's linked to sympathetic hypertonia, or what causes it?
Well, there's a lot of talk about mast cells because they produce certain pro-inflammatory cytokines that affect neurons. What we call the enteric nervous system, which everyone knows as the second brain, but its academic name is the enteric nervous system. So those neurons are kind of hyperexcited, and there are also immunological alterations, especially. And then, as you were saying, our gut is governed by the autonomic nervous system, meaning it works on its own. That is, you can't control it.
No, you don't need to control peristalsis consciously.
You can't control it. You can raise an arm, lower a leg, but you can't tell your intestine, now secrete acid, now don't, now move, now. Instead, it was controlled by stimuli from the sympathetic and parasympathetic nervous systems. All that information is recorded by the vagus nerve, which is processed at the central level. And that's what we call the gut-brain axis, which we talk about so much, right? So what happens? Well, at the level of an alteration of the inflammatory microbiota, immune activation, and neuronal excitation of the enteric nervous system, it will produce input at the level of the vagus nerve, reaching the central level, but also causing stress, anxiety, and other symptoms. More neurological or more emotional. And in the same way, neurological disorders, headaches, anxiety, and depression will produce digestive symptoms. Also, for example, at the hormonal level, you have to understand that the digestive system produces a lot of hormones. It's a neuroendocrine organ. We know that a large part of serotonin is produced in the intestines. The lack of tryptophan in the diet, which is a precursor of serotonin. It has been seen that patients with irritable bowel syndrome or digestive disorders have decreased levels of serotonin. That could also be a little bit in that.
Even though it doesn't directly cross the barrier, or most of it doesn't cross the blood-brain barrier, it acts through the nervous system, meaning it influences the nervous system via the vagus nerve and stimulates the afferent branches. To also send a message to the nervous system that not enough of that neurotransmitter is being produced. In other words, the nervous, immune, and enteric systems are totally connected, and there are many control points. I see that things can go wrong if we don't take care of this, right?
Exactly. I mean, there's not, let's say, a single culprit or a single negative effect, but rather, as with everything in our body, there's not just one villain. Instead, many of them in a patient who is genetically susceptible or with a immune or immunological disorder, or all those factors come together to cause an increase.
Yes, and also what I see is that the damage is also synergistic in the sense that, let's say, a bad emotional situation, chronic anxiety caused by another problem in life. It will also weaken the digestive system, and it will make whatever we eat that's not healthy affect us even more. Negatively, maybe in a person with a perfectly stable life situation, right? So there's a bidirectionality there that can be positive or negative.
Just think that, as you well know, we, at the intestinal level, produce a lot of hormones like dopamine, serotonin, gamma aminobutyric acid. So these types of hormones are going to have, let's say, at the level of intestinal cells, a series of functions. For example, dopamine acts at the level of intestinal contractility, of peristaltic movements, and yet at the central level it has an effect on emotions.
Yes.
Serotonin, it also has many effects on the intestines, on the secretion of substances, but in the brain it has other functions. So all those neurotransmitters that circulate throughout our body, a large part of them are produced in the intestine. Well, that's where the organs interact, okay? So they're going to produce a series of effects or different symptoms.
Local ones. Yes, yes.
Local ones or others?
Okay, I want to ask you the following question, and it is, do you think that the general population, let's generalize, is absorbing well the nutrients they get from their diet? A complete diet is generally said to provide all necessary micronutrients. But I want to ask you, so you can give your honest opinion, do you think there is something like a chronic low-grade malabsorption in the population? Because, of course, the idea that we live in a dysbiotic society, which I really liked, makes me think that we really don't have perfect absorption. And we're getting all the micronutrients because then we see that, yes, there are a lot of subclinical micronutrient deficiencies that go completely unnoticed, right? So are people absorbing everything they should?
Well, look, starting from the beginning, I'm not an agricultural engineer, nor do I work in agriculture, but I am very interested in the topic of nutrition. And I asked many professionals from the University of Agricultural Engineers, starting with the fact that many of the foods we eat no longer have the micronutrients or the micronutrient density they used to have, because probably industrial production,
The poorer soils?
the poorer soils, and then wanting to move towards mass production. I mean, usually I'm talking from without being an agricultural engineer. But of course, those fruits, those vegetables that have to be really big, perfect, shiny, have a lot more water and much less nutrients. So starting from there, then we see that we have an increasingly medicated population, whereas before we weren't taking so many medications. We've taken a lot more antibiotics. That impoverishes our microbiota. Our microbiota is essential for absorbing certain nutrients, fiber, but it also produces folic acid, vitamin B12. It produces certain postbiotics, which are also key micronutrients for our health. And then also, for example, let me give you a clear example. Omeprazole, hypochlorhydria, and the chronic use of omeprazole in society, what I call the omeprazoleization of society. Well, that hypochlorhydria makes you absorb less iron, less magnesium, especially vitamin B12 as well, and obviously you absorb fewer nutrients. How many older people, let's say, aren't taking omeprazole chronically every day? And you don't even have to be that old.
Yes. Any episode in life.
I have gastritis.
You keep it forever.
If you keep it forever, I'll be on omeprazole for life.
And what do you think about that? Because I see that every day, both by family doctors and also gastroenterologists and also other professionals from different specialties. Why do they do that?
Well, because I think omeprazole has been a very well accepted medication since it has cured many gastrointestinal health conditions like gastroesophageal reflux disease, severe esophagitis, gastroduodenal ulcers, and it's also a medication, well, apparently safe without major side effects. Now we're starting to talk more about all the long-term side effects of omeprazole. And so, well, it turns out to be relatively convenient. And then also, let's see, I noticed that many times patients, there's too much focus on the nutritional and lifestyle changes required for treating that disease. So sometimes, we tend to prescribe a drug that we're happy with because it doesn't have many side effects, at least in the short term. But that patient needs to lose weight, correct their eating habits, and make a nutritional plan for certain foods that can cause more reflux or increase gastric acid hypersecretion. So that's hard. That personal effort, as I tell my patients, I say, this is a win-win. I can give you tools to help you, but you have to use them. Maybe they prefer to just take an Omeprazole and keep going. So, and then I think there's no adjustment to the treatments. I mean, if a patient has gastroesophageal reflux disease, has an ulcer, of course they have to take Omeprazole. But then there has to come a time when you have to start tapering off.
The prescription, right?
And so, well, that's it. That's the follow-up, second evaluation or checkup doesn't occur. And then it's true that I use them a lot. I really like functions. I call them barrier functions, right? Which are products that they don't cause hyposecretion. It's not like Omeprazole. And there are a lot of really good products on the market that work very well, but they act like a barrier. Like if you put a layer of varnish on.
To the cheap one or?
Well, for example, there's the insulfate and hyaluronic acid, which especially for protecting and revitalizing the barrier function esophageal. There are certain prebiotics like xyloglucans to strengthen intestinal function. Also, polycaptyl at the gastroduodenal level. That's how I explain it to my patients. This is like putting a moisturizer or sunscreen on your face so your face feels more protected. Well, it's the same, but inside the digestive tract. So I like to use these products in patients for whom I'm already tapering off Omeprazole because they protect their intestinal barrier functions and their digestive mucous membranes.
Without altering?
Without altering the pH and without causing long-term hyposecretion. Now then, at the same time, I accompany this with nutritional corrections or with the nutritionist. And then obviously, if there are specific episodes of acid-peptic hyposecretion, we have to...
You can score it. Yes, many people develop that dependence. I saw it this week with a patient who had gastroesophageal reflux disease 6 years ago and was already fine without symptoms. He had been taking Nexium, I think it was, right, all this time, and he had that attachment to the medication because, of course, he thought that if he stopped taking it, the symptoms would come back.
Well, many times there are also those patients who go through that. Now, I'm going to talk about an economic issue, right? Of course, Omeprazole and Nexium at the pharmacy, they give it to you with a prescription and it costs you very little money. Buying a dietary supplement that isn't covered costs money, or it costs more. It's not very expensive, but it costs more. I don't know if that economic factor, the medications that aren't, that's what happens to us in Spain. In Spain, nothing seems funded. Well, many times in the long term, those chronic treatments or, well, chronic or whatever.
Of course, that's the thing. I don't think it has to be a lifelong treatment either, right? What's missing is the pharmacological education. Like, hey, this addresses a condition that doesn't have to last for life. We're going to reevaluate the medication to see if you need it or not, because taking it for life has those other negative aspects.
It's excessive treatment causing diaphoresis, hypomagnesemia, and poor absorption of iron and vitamin B12.
So, well, it's something for all the professionals listening to reflect on, right? We're going to talk about something really important, which is the role of the microbiota in cardiovascular disease. We already know that it's the main killer in the West, closely followed by cancer. A study has come out that, very recent and very controversial, which is the study on imidazole propionate, published in Nature. I think you also published something about it with our dear Jose Avellan, also from Murcia, your colleague. Tell us a little about it. What was observed in that study and what is the relevance of the findings?
Well, here we go. We're already in the field of metabolomics, right? Which is a super interesting field. Like the gut microbiota, I go back to the microbiota, produces more than 50,000 metabolites, so they can have an impact on overall health. So what this study is saying is that in some patients, microbial groups, although they haven't been precisely identified which gut microbiota or taxonomic groups are responsible for producing them, the increase of a substance called imidazole propionate, has been directly linked to subclinical cardiovascular risk, independent of cholesterol levels, right?
Okay.
So what this is basically saying is, kind of what we already know. It points out that a metabolite is very important, a substance that can be useful to us as a biomarker, right? Which is produced by the gut microbiota, and through that intestinal barrier function, it passes into the bloodstream. What could this be? It's still being investigated, as most studies so far were in mice and showed it could enter the circulatory system, and it could serve us as a biomarker to predict the cardiovascular risk of patients.
Which microbiota produces this molecule?
We're still waiting a bit on that.
Okay, it hasn't been linked with...
A microbiota that's mostly pro-inflammatory, which decreases the production of, especially butyrate, it decreases the production of short-chain fatty acids. And indeed, in the end, it's like fishing. It's a vicious cycle. What does a pro-inflammatory microbiota produce? Well, habits, including nutritional and lifestyle habits. And as I always say, diet is the architect of our microbiota. So what can we do? Well, we go back to diet, to fiber, to omegas, to healthy fatty acids to strengthen that gut microbiota.
Yes, and so people understand that it also exists, right? A gut microbiota hard axis, right? In the sense that what happens there also has a direct influence on cardiovascular health.
Cardiovascular health, as I say, the gut axis, gut and brain, gut and liver, gut and cardiovascular, gut, not everything, neurological gut, gut muscle.
Yes.
It's like, right? It's the axis of overall health.
Yes, it's the entryway for everything. Like the skin, the intestine also has direct contact with the outside. People often see the intestine as internal, but the contents of the digestive lumen are technically outside our body. I don't know.
Exactly.
Visually, it's strange, right? But if you think about it, the intestinal contents are outside your body. Only what it allows in enters your body.
What it lets through.
The barrier, right?
Yes. Like that, we go back to the concept of those 70 tons of food that have to be processed at the intestinal level. And I, who often go to many conferences, have many talks in the pharmacy and the dermopharmacy sector. And I also meet with many dermatologists because the skin is the largest organ in the body. And I
count the hairs and try to understand them, right?
And I say, these people haven't seen the intestines I see through endoscopy with all their villi. If I were to stretch them out, they'd be bigger, actually bigger than a field of...
A soccer field? Yes.
The other day they told me, a soccer field, not a tennis court. I agreed.
All right, I'll give you that.
But we're aware of three... if we were to stretch out our intestines, it's a surface, right? Depending on the size of each of our phenotypes. But 300 square meters. Just imagine 300 square meters. Producing pro-inflammatory cytokines, metabolites that enter our bloodstream and go there once they enter our bloodstream. Well, it reaches any organ.
Of course.
And then it does its thing there. If you have some anti-inflammatory metabolites, then you'll have a protective effect. And if you produce some pro-inflammatory metabolites, then you'll have an effect. Well, a low-grade chronic inflammation.
Of course. What role does the vagus nerve play in, let's say, maintaining digestive health? Now that there's so much talk about the vagus nerve.
Well, the vagus nerve is the 10th cranial nerve. And it's called vagus because it's the longest one in our entire body. And well, that's not all. Besides its digestive role, it also regulates many respiratory and cardiac functions, and in the digestive system, it controls important activities such as gastrointestinal motility. It's what tells our intestines, well, now move, depending on whether we're with the system. Sympathetic or parasympathetic if the nervous system is in another mode that we've talked about before. And so then the vagus nerve arrives, it goes into the wall of the intestine, okay? It's a neural network that is, much denser than the spinal cord itself. Everything that lines the digestive system and regulates, digestive motility, when it needs to be doing intestinal peristalsis, when it needs to stop the acid peptic secretions, it tells the acid-producing cells in the stomach, now you secrete hydrochloric acid, now you stop secreting hydrochloric acid. When food passes into the duodenal lumen, it moves from the stomach into the duodenum. It says, now you don't produce hydrochloric acid. Now we're going to secrete bile salts and acids. pancreatic juices because the biliopancreatic secretion is starting. So now we're going to, the vagus nerve controls everything.
It's everything.
From speaking in medical terms, well, inside the intestinal wall, there's the myenteric plexus of Auerbach. That's what it's called. And the Meissner's plexus, one is in the submucosa, which is the one that produces all these metabolites and activates the cells to produce hormones. And the other is in the intestinal muscle layers. The layer?
Yes, deeper, right? The smooth muscle.
The smooth muscle to produce intestinal peristalsis, okay? So when we talked earlier about the bradiointestinal function, which has many structures, well, starting from the top, mucus, microbiota, enteral cells, the immune nervous system, the Auerbach's myenteric plexus, the submucosal layer, the Meissner's myenteric plexus, the longitudinal muscle layer, and then the serosa. All right, that's what
it covers.
It covers or gives firmness to all our internal organs, so they're not just loose in there, but instead are all well contained. Now, therefore, the vagus nerve is what controls everything. It controls all our digestive mechanisms.
And that's why when there's sympathetic overexcitation, we're anxious, nervous, overtrained, or not sleeping enough. Just got off duty. Everything bothers your digestion. You can't digest anything. That is...
You lose your appetite.
You get a stomachache, you have to go to the bathroom with the slightest change, right?
Well, who hasn't had diarrhea after an exam in the MIR right before going in? Or who hasn't had butterflies in the stomach when it occurred?
Bad news?
Or crisis, the lump, the anxiety it generates. Well, bad news, my stomach tightens up, right? We've all felt that, right? We've all had those experiences. And the digestive system is very, very sensitive, very susceptible to all those effects. Also, for example, at the cardiovascular level, it's the same. The vagus nerve, when you start having palpitations, well, all of that is connected.
Of course. And as a digestive specialist, what do you think about intermittent fasting or taking periods of digestive rest?
Well, I think it's a very good strategy as long as it's guided by professionals and done properly.
Okay.
I think about 12 hours. Intermittent fasting, we can talk a lot about that, right? But there are fasting periods and eating windows. Let's talk about the 12-12, the 16-8, that kind of thing. At minimum, a fast that's essentially physiological, right? It should be like a strategy. Well, at 12-12, we should be able to do it. And then, well, everything from a digestive point of view. And it's very well documented in the literature. The whole topic of the fasting mimicking diets, but from my point of view, controlled over short periods of time, about 5 days approximately, framed within a program or a project of an anti-inflammatory diet or a diet that is well targeted in terms of micronutrition, comprehensive, where, well, especially in all anti-aging and longevity strategies, it activates certain cell regeneration, apoptosis, and gut microbiota improvement. I recommend them frequently. And while in our practice we have a program, we call it the Renew program. It's a controlled 3-week program with 1 week of an anti-inflammatory diet to introduce fasting, reducing sugars and carbohydrates, okay? And certain types of nutrients. And then a period of a controlled 5 days. It's like a fasting mimicking diet where you consume about 500 kilocalories. Everything is already measured, weighed, super controlled. And this is to eat foods that are 100% natural, with no additives, no preservatives, and no colorings. We simply dehydrate them so they can be and preserve all that micronutritional value, and so they can be easily transported. And then a week of coming off the fast. We recommend, well, maybe doing that program every 3 or 6 months, and honestly, we have really good results, both with patients with digestive disorders as well as patients with inflammatory autoimmune diseases, and of course metabolic syndromes or patients with hypertensive metabolic problems.
Because what happens in the intestine while fasting? Are there regeneration or self-regulation processes that...
First, rebalance the gut microbiota. So that decreases certain pro-inflammatory groups, and let's say it activates cellular regeneration mechanisms, improves apoptosis, autophagy, our epithelium, our digestive system. It's similar to skin, which constantly undergoes rapid cellular turnover.
High, right?
And it's highly vascularized and has a high cellular turnover, and it's constantly shedding intestinal cells. In this case, we excrete them, right? With bowel movements, but it's constantly renewing and re-epithelializing itself. So improving those autophagy mechanisms, that cellular cleansing, those cells, the senescent cells,
Yes.
that we have throughout our entire body. But the digestive system is one, since it triggers cellular regeneration mechanisms.
Of course, because we easily understand that the muscle can't always be active, or even the brain can't be working continuously, right? But with the digestive system, we never really give it a break, right? We eat every 90 minutes throughout the day, and some even do so at night, right? So yes, in the end, like you said, it's not about doing a 24-hour fast frequently, but about fasting at night. Let it stop.
Of course.
And then
not only at the digestive tract level, but when you're eating, you're also activating pancreatic secretions, increasing insulin production, and creating insulin spikes. So, well, you're an expert in the field, right? All the impact that insulin spikes and insulin resistance have. So that's why, especially in people with metabolic syndromes, prediabetes, hypertension, prediabetes, the strategies, I want to call this program Renew because I don't want it to be just a calorie restriction program. It's something much broader, which is embedded within an anti-inflammatory diet approach. The groups of patients we've already worked with have a very refreshing idea. Also, because they realize that you don't need to eat so much to feel good.
of course.
They kind of break away from that concept that we have to be constantly eating. My blood sugar's dropping, I need to eat.
Like a psychological attachment, yes.
Of course. So they realize when they come in, they dedicate time to themselves. They look for time to be able to do it, which isn't that complicated either because you have everything done. It's more of a mental shock. And you realize that by the third day of being on a calorie restriction, you already have energy. You increase the secretion of ketone bodies. You activate certain neurotransmitters that also have an effect. Well, they feel strong. They feel, yes.
They feel strong, light, and focused.
And focused. It improves headaches, migraines. Well, they say, wow, this isn't like what I was told.
Yes.
And they notice it. They notice it on a level?
Of course, quickly, yes.
What I don't agree with maybe is with very prolonged fasting programs. No.
Also, they don't really have much evidence they have more risks than benefits, very few proven benefits. And there are definitely risks.
This program with this strategy, the patient notices the effects, it's well managed, and then it kind of, I've noticed that it kind of does a metabolic reset. It's like your metabolism was slowed down and then something suddenly activated it. And many patients notice, that they already get into it's not weight loss, but reduced inflammation.
It's a dynamic in which it's easier for them to maintain the results, right? It's less difficult for them. All right, doctor, how can we know if our microbiota is actually healthy?
Oh, that's a great question, isn't it? Well, right now, with everything going on in the field of microbiota, a lot of diagnostic tests have come up, and patients go online and search for microbiota tests. And I get a lot of patients coming to my office asking me to interpret those tests for them. Well, they're sometimes debated by the scientific community, let's say, regarding their usefulness. But you have to know very well that not all tests are the same. So the test can give you a snapshot of your microbiota at a specific moment. We know the microbiota is temporary.
Dynamic, right?
And it's dynamic. And the results you have today might not be the same as tomorrow's or those in 3 or 6 months. But I do think it's a tool as long as it's certain types of tests. I don't agree with all of them. Very interesting tools to find out what microbial imbalances you have. and to be able to personalize a nutritional plan or a therapeutic strategy, or to personalize things if there's a health problem, supplements, treatments, dietary supplements, or medications. For example, more and more people are talking about small intestinal bacterial overgrowth, which is usually diagnosed with a hydrogen breath test using an expired air kit, as there may be. If you have hydrogen small intestinal bacterial overgrowth, methane small intestinal bacterial overgrowth, or small intestinal fungal overgrowth, the fungal one, then the hydrogen breath tests fall short because you can detect an increase in hydrogen or methane, but I'm not telling you about the microbial groups that are altered. So this type of test gives you more information and provides you with tools to personalize your diet. If I know that I have an alteration in the mucoprotective microbiota and I have a decrease in Akkermansia or Faecalibacterium praunici, then I know that I need to develop a nutritional strategy and at specific times use dietary supplements, let's call them that, or products or medications to strengthen that intestinal function.
Okay, I mean, you, of course. For us, professionals who don't specialize specifically in microbiota, it's difficult to provide personalized lifestyle guidelines when we see that kind of test. But maybe you guys can be more precise, right? Dr. La Puerta, who also specializes in microbiota, was here long ago. And maybe you guys really can have that approach of, hey, look, let's fine-tune this. You need to strengthen the barrier function or the function of the lactobacilli or whatever function is needed. That can be done.
Absolutely, that's right. This is a specialized area of medicine, like so many others. Maybe I wouldn't dare to deal with hypogonadism or a pituitary adenoma. That's why we have wonderful endocrinologists who do an amazing job. In my clinic, 2 pediatric endocrinologists and 1 adult endocrinologist treat those patients. I handle everything related to microbiota myself. I take care of it, but I do it myself. Please explain clearly, as patients sometimes bring me microbiota tests from 1 or 2 years ago, which aren't useful to me. This is like a blood test, where at that moment you had those results, but now there might be something different. There are many tests available, but they are not all the same. So yes, for example, the tests that have the most scientific evidence and are used in research studies at universities. In the papers, these are the genomic sequencing tests, where you do next-generation sequencing and metagenomics. And those are really the tests where you can get some real information of validity, because there are many tests that might be more affordable or that use polymerase chain reaction or other types of methods that aren't as reliable. So you need to know what test you're doing, which lab you're working with.
And they exist in the industry. I mean, can those sequencing tests be purchased?
Well, let's see. I have them at the clinic, and the ones I work with are from a lab where there are molecular biologists and geneticists.
Okay.
I mean, why? Because I know they're running reliable microbiota tests on me. They're doing a lot of taxonomic studies, metagenomics, which, as I always tell my patients, the test is important and you need to know where to get it done and that it's reliable. The key thing is interpretation.
Of course.
I mean, wherever you go with any evidence. I don't get why people say, I want a microbiota test. The why? What's the issue? Who's going to interpret it for you? I mean, the value of the test is the interpretation by a professional who has studied the subject.
And also, what worries me is what I mentioned before about the dynamism. That is, the microbiota changes depending on whether you've trained, if you've slept more or less, if you're more or less stressed, and your diet. Obviously, there are so many things that are so dynamic that I don't know to what extent a specific snapshot gives you accurate information.
Well, it's like a blood test. When you go to get a blood test, because many times you do it just for prevention. I want to know how I am. Well, it's the same. Usually what happens is that the people who go for that kind of test are patients who have some digestive symptoms or are experiencing pain or intolerance. These patients say, I don't want to eat this or that. Everything upsets me. Even drinking water burns my intestines. I mean, these are patients where you say, well, what's going on here? Why is there such an exaggerated visceral hypersensitivity? In this patient who has already had an endoscopic study, I mean, there's no major endoscopically visible pathology. Well, so you understand that there is low-grade intestinal inflammation, that there is an alteration of the intestinal barrier function, and you want to develop a strategy to strengthen that intestinal barrier function. So you want to do it not with the standard diet, which we all know what it is, or more or less, which is eating well, but you want to associate those results. Well, I have to increase this type of polyphenols, so I have to increase these fatty acids, these omegas. Well, I have to work on strengthening my gut barrier function, so if I have pro-inflammatory groups, I need to give anti-inflammatory products. So, and then when it comes to taking prebiotics and probiotics, because people take probiotics like there's no tomorrow, I mean, they go to the pharmacy and take these strains. You have to know, I mean, each strain you take, what its health indication is, and whether for your specific problem, that's the right strain. Of course, they take probiotics without guidance.
Right. Yes.
This helps to personalize nutritional interventions and the strategy for treatment and supplements. And you see that some of them have dysbiosis and maybe have pathogenic groups or something like that. So you put them on a cycle with rifaximin and neomycin.
And they get better, right?
Well, usually, yes. Usually. The disciplined, responsive patient also needs to be told that this isn't something where you come to the appointment one day, get a treatment, and just leave like that. I mean, it takes a process some time. And sometimes we also use, for example, when patients are very reluctant, a lot of neuromodulators because of that gut-brain axis. Amitriptyline, sertraline at a low dose.
Oh, I didn't know that. They can also help improve.
Absolutely. It's in all scientific societies' clinical practice guidelines. And we use those medications, but at a very low dose to improve and reduce that visceral hypersensitivity. So what happens is that sometimes I come across a type of patient who is very reluctant. No, I don't want to take it. I think that, or they associate amitriptyline and sertraline only with the field of psychiatry, as if we prescribe them only for crazy people or for, I don't have any problem and I'm not stressed. I say no. Yes, I know you're not stressed. But there is a visceral hypersensitivity due to the vagus nerve or the gut-brain axis. And these medications, we don't use the psychiatric doses. They're actually very low. They will
help you
to recover. That's true. Studies show 70-80% of patients with neuromodulators for functional digestive disorders improve.
And Pilar, earlier you said that you mainly focus on endoscopy in the public sector, that you do a lot of endoscopies and see patients who have symptoms. Some of them can be diagnosed with inflammatory bowel disease based on endoscopic findings because they also meet all the criteria and so on. But there are others who are in a sort of limbo where no macroscopic changes are seen. You don't see the alterations that you see in Crohn's disease, for example, or in ulcerative colitis. But when we do a biopsy, when you do it and analyze it, you already see certain changes. What do you see in those biopsies?
Well, look, what we see, as you said, is a healthy intestine, endoscopically visible with no signs of inflammatory activity. Sometimes you do see small ulcers or inflammatory lesions, small ones, but they're very non-specific and not conclusive of disease. With biopsies, you often see increased intraepithelial lymphocytes reflecting the intestinal barrier function we discussed earlier. We have the cells and then below, those castle guardians, which is our immune system, right? So then you see that we have an above average increase in immune cells, more than what you would expect in a normal biopsy sample. So this is telling you that there is a circumstance that is causing you intestinal inflammation, let's say of a low grade. That is activating your immune system. This is going to activate antibodies. This is going to cause, well, it makes your intestinal wall, your intestinal function weaker. And these are patients who remain in a sort of treatment limbo because they don't have an indication for intensive medical treatment cycles, like we give in Crohn's or colitis with corticosteroids or with immunomodulatory or biological drugs.
What is the general message that most gastroenterologists or colleagues from the specialty usually give when we find ourselves here in this limbo? Because people often say, yeah, just live normally and eat what you wanted, but that's not true.
That depends on how much time you want to spend with the patient and how much you want to explain. Or in the environment you move in, how can you promote or encourage your healthy habits? So unfortunately, as you know, in public healthcare, maybe you don't have the tools or strategies to create a nutritional plan there, and it's just not there. And then I think we convey the message wrong, because many times in public hospitals, that's how we're focused. Do you have a disease? Do you have a disease? Do you have a disease?
Yes, but I've noticed that even with a disease like Crohn's, no, this isn't about nutrition. You can eat anything you like.
That's not right.
You can see it, right?
Well, maybe it's because there's a lack of knowledge about nutrition in that type of patient, or maybe the doctor doesn't have a unit. There's no nutritionist you can refer the patient to within the hospital so they can get proper nutritional counseling. Like I said, there's no nutritionist at the hospital because the public system doesn't have one. You have to explain this to the patient, and if they can, in hospitals we can't meet all the health demands, but the patient can look for help wherever.
Many professionals.
There are many professionals working in the public sector, in the private sector, or wherever they think they can help them. And objectively, obviously, that's great. I don't know. Food, digestive diseases, nutrition, and the digestive system are like Siamese twins. So you can't treat any disease of the digestive system without including lifestyle changes and associated nutritional changes. You won't treat the disease properly, and both the patient and doctor need to know that.
Of course, it kind of frustrates me, especially when I even have a friend or a colleague with Crohn's disease, you know? My gastroenterologist told me I can eat whatever I want now that it's under control. Fortunately, we're making steady progress.
I think that message is changing, and I think that nowadays, I think almost all doctors are very involved in that topic. One of the things I currently lead in nutrition at the Spanish Foundation for Digestive System and the Spanish Society for Digestive System. And it's a bit about professionalizing or personalizing or all the dietary and nutritional guidelines for the different diseases of the digestive system.
Wonderful.
It's one of there are going to be resources that will be there for patients and professionals to be used during consultations.
Yes, it will be very useful for sure, yes.
Let's see if I can do it.
Well then, Pilar, if you want, let's wrap it up. Let's give a message from you to the audience, whichever you want, the most useful message you want. People worldwide will be watching us.
Yes.
Take advantage of it.
Well, I want you to
focus on gut health as the key to overall health. As if you take care of your gut and your digestive system, you're taking care of your cardiovascular, metabolic, and neurological health on every level. Trust the professionals, look for accurate information, and follow all the prevention strategies. When it comes to digestive cancer, fortunately, there are more and more prevention strategies available. And will take care of your gut microbiota.
Absolutely. Lifestyle is fundamental. I think you've covered the key points today. Anyone wanting to listen and understand now has all the key information to care for their digestive system and health. So that's it. We thank you from Mejor Que Ayer for coming here to Malaga to record and spend some time with us.
Thank you. It's been a real pleasure.
Great. Well, we hope to see you in the future.
Well, it will be a pleasure.
That's right, guys. Another episode of Better Than Yesterday. I hope you've learned a lot and that you take away clear and practical guidelines to improve your health. A big hug. See you in the next episode and keep empowering.